everybody. Welcome to the April meeting of the Kansas COVID Vaccine Equity Task Force. Before we begin, the usual announcements. Task Force operates in compliance with the Kansas Open Meetings Act. This meeting is being recorded and live streamed on KDHE's YouTube channel. Please mute yourselves when not speaking to prevent audio interference. So nice to see everybody. Welcome to anybody who is here for the first time. My name's Jimena Garcia, and I'm the governor's senior advisor for vaccine equity, and I'm going to be leading this discussion today together with my colleagues from KUMC and also KDHE. So I wanted to start by doing a quick review of the agenda, which is super full today. I don't know if you, yeah, thank you, Vicki. Okay, so I'm going to start by sharing the state of COVID infection in Kansas, and then introduce the new Test to Treat program. From there, Jamie Gable will share the latest COVID vaccine data. After the vaccine update, we're going to hear from Laura Canelos, who will go over information about the impact on Kansans who have Medicaid that the end of the public health emergency is going to have. After Laura will give an update on the most recent legislative actions. And from there, Dr. Duvey, our state health officer, will give us a brief primer about Mpox and the state of the outbreak in the United States and Kansas. And then we're going to move to the heart of our meeting, which I'm super excited about. And that is going to be hearing from Tori Gleason, Mary Gonzalez, and Kayla Del Rio, three health professionals who are going to share experiences about the impact and response of Mpox from the community. So let's jump in. And to save time today, I hope it's okay, we're going to skip our usual introductions. I just ask that you put your name and organization into the chat. So if we could move to the first COVID slide. Okay, so here's a weekly COVID case rate shown by state on this map of the US. And this is as the numbers as of the end of March. So the darker the blue, the higher the case rate. So for context, this month, the case rate per 100,000 is 42. And last month it was 77. So we are down by almost half of the cases per 100,000 compared to last month. So looking at the situation in Kansas, next slide, please. So this graph shows the number of new cases per day and the 7-day rolling average number of new cases starting at the beginning of 2022. So if you go all the way to the far right, for the week ending April 1st, 2023, the average number of new cases per day was 129. So for context, a month ago, it was 247 new cases per day. So we also are seeing new cases down at about half of what they were this month compared to last month in Kansas. So next slide. So I want to spend a few minutes talking about a new program for accessing treatment for COVID. So one thing that we've heard repeatedly from community members is that getting treatment for COVID can be difficult if you don't have a regular doctor, if you can't afford a doctor, if you can't get to a doctor and or can't get to a pharmacy that stocks treatment for COVID, a lot of people just end up not getting treated. So luckily, this access issue was recognized by public health people at the federal level, and they have introduced this new no-cost program, which is aimed at reducing barriers for treatment. So the website for it is testtotreat.org. And although it doesn't remove all barriers, it really removes many. So you have to be 18 years old to access it. You have to speak Spanish or English and have an email address. You don't have to create an account, but you do need online access. And the program is actually amazing. It provides a free test if you need one, delivered to your house. It provides a free telehealth visit with a provider. And if you require medication, the medication's delivered to your house, all at no cost to the person. So keep in mind that this program is really meant for people with financial barriers to accessing doctors. So not really for people with insurance or the means to go to the doctor. But bearing all that in mind, please make sure your community partners know about this program, especially in Kansas, where it's been hard for folks in rural areas to have easy access to COVID treatment. This is going to be super useful. And after the meeting, we're going to share the slides via email so you can have the QR code and the website information. So with that, I'm going to pass the floor now to Jamie Gable, Senior Epidemiologist at KDHE. Thanks for being here. She's going to review the most recent vaccine and booster rates in the state.
Thank you so much for having me, Dr. Garcia. And in the interest of time, because I know you have a really great agenda today, I will try to go through these fairly quickly. So please bear with me and contact me if you have any questions afterwards. Our first slide is the overview of vaccine uptake in Kansas as of last Wednesday for 1-dose completed COVID-19 series and bivalent booster doses. Since we last met in February, there's been very little increases overall across the board. In most cases, just 1.1 or maybe 0.2%. Next slide, please. So our next slide is vaccine uptake for having received at least 1 dose of COVID-19 vaccine for Kansans under age 18 by race and ethnicity. So this slide shows our uptake over the past couple of months. And so the major change to look back here is that we took everyone's feedback about native vaccination rates, and today we have it displayed a little bit differently. So we have only race AIAN and any race AIAN. So only race AIAN, which has a coverage of 8.3% in Kansas children, are those that are in WebIZ that have native indicated as their only race. So that's how the other race fields are calculated for this slide. And any race AIAN are those that have only AIAN as their race and those that are multiracial and have AIAN as at least one of their races. So the coverage is much higher at about 59%. So basically it adds those that are multiracial that have AIAN to the only AIAN group. And it'll give a little bit better idea of what the coverage looks like for natives in Kansas. I also just wanted to have a quick plug to remind everyone that when we calculate race, it's done independently of ethnicity. So what I mean by that is if somebody were Black and Hispanic and Latino, they would be included in the rates both for Black and for Hispanic and Latino. And when we look at the slide now, if somebody indicates that they're Black, Native, and Hispanic or Latino, they would be in the rates for any race AIAN and in the rates for Hispanic and Latino. Next slide, please. So this slide is going to be similar information as the last, only we're looking at adult Kansans, and so that's Kansans over age 18 and older. So we see that rate adding the any race AIAN metric provides much higher coverage, so at about 85% when we're looking at that compared to only native is the race. So in general, across the board, we're seeing very small increases over the past couple of months. And if in the future, everyone would prefer that we look at only when I say only, I meant any race AIAN metric, and just have that one displayed over time like we do with the other races and leave out the only AIAN metric, we can do that. I'm happy to accommodate what people think is the best way to look at things. I really would like to hear any feedback anyone has about that. You can email me or Dr. Garcia. Next slide, please. So this slide, we have bivalent booster uptake across the different races and age groups. AIAN data for this is reflected anyone who has any race indicated as native as one of the races. So with that update, they have the highest coverage for all of the different age groups. White has the second highest coverage for adults and older adults, and Asian has the second highest coverage for children. And you can see that there are groups who definitely have a little bit lower coverage across the board as well. Next slide, please. So this slide is going to be similar as the last one, but this time we are looking at ethnicity instead of race. So while we see higher coverage in Hispanic and Latino for having received 1 dose, we actually see the opposite and see higher coverage for non-Hispanic or Latino for all age groups for the bivalent booster dose. So that is what we have for data slides today. And as always, please feel free to reach out to Dr. Garcia or myself with any feedback, or if you have any questions that we're not able to answer right now, or anything you'd like to see in the future. Thank you.
Thank you, Jamie. And thanks for rethinking the data, the way you show it. Those low rates of bivalent booster really hurt my heart, but most of us on this call are still working as hard as we can to improve the rates. So thank you to all of you who are still working on this, and don't give up. We clearly still have work to do. So I'm now going to pass the floor to Laura Canelos to provide an update on what the May 11th expiration date is going to mean for the end of the public health emergency order and what that's going to mean for people enrolled in Medicaid in Kansas. So we have 5 minutes for this topic. Over to you, Laura.
Thank you, Dr. Jimena. Hi, everyone. I'm Laura Canelos, Director of Community Outreach for United Healthcare Community Plan of Kansas. We are one of the 3 MCOs that provide cancer in the state of Kansas. I am going to be very brief, but if you have any questions, want more in-depth, want a presentation for your staff, want materials, anything around this topic, please let me know. My email is in the chat. As you may have heard, because PHE is ending, now states are restarting the redetermination of the eligibility of members on Medicaid. And these already started in the state of Kansas. The first batch of members received their notices mid-March, and is going to continue until March 2024. And they have a month to return the renewal form, complete it, or do it online. If they don't, at the end of that second month, they lose eligibility. So at the end of this month, we're already going to see a lot of people losing eligibility. A lot of them will lose eligibility no matter what, because they have aged out or they are past the 12 months post-pregnancy. But a lot of them are still eligible, particularly children, for example. And it is really important that they respond to that notice and send it back so they can keep their eligibility. There is a lot of amazing navigators on the ground helping people with this. But one of the main barriers that we know are present is folks have not updated their address with Cancer. So Cancer will send the information to the address they have, and then people will know that they were supposed to renew and might learn that they have lost eligibility 2 months from now when they're going to the doctor, for example. So again, please let me know if you want more in-depth information about this. I do have these very handy flyers in English and in Spanish. We have a lot of materials United Healthcare branded, even though the information applies to all members of the 3 MCOs, but we also produce these ones with no logo of United Healthcare, so it was easier for people to understand and to share. And we have these pads that come like this, very handy. You can just steer them and help spread the word. Let me know if you want some of these. Just send me an email with your address and we're happy to ship as many as you need or want so you can help us spread the word. And that is really what I have. I also will put in the chat a link to a page that has a little more detailed information for people that might directly work with consumers, patients, members. That is very valuable. But again, please let me know if you need more information. Thank you so much.
Thank you, Laura. And thank you so much for all the work you're doing, trying to make that transition smooth for people. Okay, now I'm going to pass the floor to Matt Lara, Director of Communications and Legislative Affairs for KDHE, for a brief legislative update. And we have 7 minutes for this topic.
Perfect. Thank you. And I'm sorry I didn't get a chance to finish my PowerPoint for this. So I will get that put into a PowerPoint. So when they send out the slides, it'll be easier for you guys to read through it. So the legislature is on spring break right now. But I will talk through some of the bills that we were tracking and that things that have happened. So they will be back on April 24th, and we will finish out the session then. Before they left, they did override the governor's veto on House Bill 2238, which was the Creating the Fairness in Women's Sports Act. They did that, I think, a couple weeks ago. Both the House and the Senate both were able to override her veto, so that is going into law now, which is the bill that requires female student athletic teams to only include members who are biologically female. Another bill that we were watching and that has passed both chambers is House Bill 2313. This is a bill, creating the Born Alive Infant Protection Act, which is to provide legal protection for infants who are born alive, regardless of the intent of the delivery. This bill passed both chambers. It is now going to the governor's desk. I don't believe she has signed it yet or made a decision on vetoing yet. And so we are watching that one closely to see what her decision will be. on that. So yes, it was sent to her desk on Friday. So we will keep an eye on that one and keep you guys updated as we move through that. Another bill that came out at their last week, and I don't know if anybody was tracking, they did work until at 4:30 in the morning on their last day of session. So we were up watching those their debates, which was fun. Fun is a relative term, I guess, but the Senate sub for House Bill 2344, there's been lots of articles in the media about this bill. This is the child care bill that the Senate worked on. It did end up passing both chambers. It establishes what the staff to child ratio should be, as well as putting in the professional requirements. It puts all this in the statute rather than what is in rules and regs now. Our agency did oppose this when it was in committee because our stance was that this should remain in rules and regs because it makes it easier for us to offer waivers or exemptions to those regulations, but once it's put into the statute, it makes it a little bit more difficult, as well as some of these things that they're offering are not safe for children. But it did ultimately pass, and it is now at the governor's desk. And so we will see what happens with that one. And obviously keep you guys updated. Another one that passed and that we are keeping a close eye on as well is 2264, which is amending the Women's Right to Know Act to add the notification requirement of reversal of abortion options with certain medications and amend the definition of abortion. This one has gotten a lot of immediate attention as well. I think what I've heard, and I'll be honest with you, our agency stays out of this one. I don't believe we took a stance on it. So what I've read in the media is it's a controversial bill because of the reversal of abortion options. It's not safe. So we will see ultimately what the governor decides with this one. And when I believe when the next COVID meeting happens, we will update you guys with those bills. 2390. I think when we had our last COVID meeting, Joan, I think, talked about this bill, and it was a bill that we were very supportive of because it was our bill. It morphed in the way the legislature likes to do things. It morphed into something that we were not supportive of. They stripped out our test strips from the bill that we had in there and put in the language from Senate Bill 6. If you guys don't remember what Senate Bill 6 is, it was the bill that restricts the authority of the Secretary of Health and Environment and local health officers to prevent the introduction and spread of infectious or contagious diseases, and repeals the authority of the Secretary to quarantine individuals in there. They also did include language from bills or Senate Bill 314 and 315, which is the bills that would prevent the Secretary from adding the COVID vaccine to the schedule of vaccines required for schools, as well as the one that we would not or prevent people from inquiring into the sincerity of religious exemptions. This bill it did not pass the Senate. It failed, and so it died on the floor, and so it is done for the year. And so we we are moving on with that one. The actual bill, Senate Bill 6, is still alive. It is on the House side. They never did a hearing on it. And so while they're not doing anything this year, it will still be alive for next year. And so we will keep an eye on that for next year. Moving on to Senate Bill 26, which was passed out of both chambers. Senate Bill 26 creates the Kansas Child Mutilation Prevention Act, which the bill allows an individual who had gender reassignment service performed as a child to bring a civil cause of action under the act against the physician who performed such service. The bill also established statute of limitations for such cause of action, and the provisions of the act would not apply if the child was born with a medically verifiable disorder of sex development. A bill passed in both chambers and is, I believe, at the governor's desk as well. We are watching that one to see what happens. The last one I want to mention is Senate Bill 180, which is establishing the Women's Bill of Rights to provide a meaning of biological sex for purposes of statutory construction. That one, I believe, also garnered a lot of media attention, and it passed out of both chambers, and it is also going to the governor's desk. So the other two that I will mention is House Bill 2269. It's a bill that our agency supported and we're very excited about. It's a bill that is increases the age of people who want to buy tobacco products to 21, from 18 to 21. That law, I believe, goes into effect July 1. The governor signed it earlier this week, I believe on Monday. And so we're excited about that one. And then Senate Bill 174. This bill is still in the legislature, but they added in the fentanyl testing strips, which is something we have worked all session to try to get passed. We have heard from legislators that there is an agreement among the conference committee members that it will be passed, but they have not put out the conference report. And so the rumors are that it will come at the end of session. And so we're keeping a close eye on that. And we will see what comes that last week of session, which is starting April 24th. And so we will keep you all updated at that point. So if you have any questions, I will be here.
Thank you, Matt, so much. Really appreciate your summarizing all that difficult information. So to move on, we're going to hear from our own state health officer, my friend and colleague, Dr. Joan Dubie. I asked her an impossible task to give a short lesson about Mpox virus and the current state of the outbreak, all in 10 minutes. So Joan, I will pass to you.
I'm going to try really hard. Thank you, Jimena. I appreciate it. And appreciate being here. Vicky's going to share my slides to hopefully, yeah, there we go. Because it would have taken me 3 minutes just to do that. So we can go to the next slide, Vicky. So I thought I would start by just sharing what is Mpox. It's formerly what we called monkeypox, and the name was changed because monkeypox was stigmatizing in some communities, and so we wanted to maintain the pox part and just shorten the front part to M. So now we have Mpox. It's a bit confusing, but I'm getting used to it. So I think it's possible. It originally got its name, though, in 1958 when it was discovered in lab monkeys in Denmark. It's a virus similar to the virus that causes smallpox, but it's not as contagious. And the disease it causes is typically milder, but in some people can be severe and even deadly, and in particular in people who have HIV that and do not have viral suppression. So until 2022, Mpox, which we think originates in animals, but not necessarily monkeys, was only known to cause outbreaks in Central and West Africa and in people who had contact with infected animals. That's what makes this outbreak different. So to date, since 2022, since about May of 2022, more than 86,000 cases of Mpox have been identified, mainly in men who have sex with men, in dozens of countries where it had never before been reported. And I want to emphasize that contact. So contact with infected animals in West Africa, in the current outbreak, it's contact between people where one of the partners is infected with Mpox and has lesions, we believe, although there is, with any infectious disease, we're always learning. And so there has been information that perhaps it can be spread by people who don't have symptoms, but we don't know that for sure. So stay tuned. Next slide, please. So the signs and symptoms of Mpox, typically Mpox causes a rash. It starts out perhaps looking like pimples or blisters, and then it evolves, and I have some pictures I'll show you. Other symptoms, though, before you get the rash can include fever, chills, swollen lymph nodes, exhaustion, headache, muscle aches and backache, and respiratory symptoms like a sore throat or nasal congestion. So very typical symptoms for other viral illnesses. But if there has been contact with someone who was infected with Mpox, who may have been infected with Mpox, we have to really start thinking, could this be Mpox, and really watch for that rash. Next slide, please. And the Mpox rash, the middle one is sort of early manifestation of lesions. You can see they look just almost like chickenpox, really, but they're red, a little blistery. They evolve and they become a little bit more pus-filled and firm. And then the picture on the far right is the end state, which shows them crusting over. And you can see that central belly button. We call that an umbilication. And that is pretty typical for Mpox. Next slide, please. So in Kansas, we have 50 individuals who've been identified with Mpox, and they have come from 10 counties. 12% of those have been female, which is very atypical. Nationally, that rate is under 1%. For males, 88% have been male. 84% have been white, 14% Black, and 2% Asian. So you can see our Black and African American Kansans have been disproportionately impacted when we think about the overall rate of African Americans in our state. And 26% have identified as Hispanic. And again, that is an overrepresentation of Hispanic ethnicity in people who've been diagnosed with Mpox. And we can see as of April 12th, there have been over 30,000 total cases with 42 deaths in the United States. We have not had any deaths in Kansas. And I want to say that we have had individuals who've been extremely ill with Mpox, and thanks to the good clinical care they have received in consultation with the CDC from our infectious disease and family physicians in the state, we have had good outcomes. Next slide, please. So if you are exposed to Mpox, here are 3 steps you can take. Watch for your symptoms for about 21 days from your exposure. You can consider getting vaccinated, because we know that early vaccination within about 4 days of exposure can actually prevent the development of symptoms and disease. So vaccination is really critical if you've been exposed and you are currently unvaccinated. And most importantly, if you have a new or unexplained rash or other symptoms, see your healthcare provider. Because as I said, if you have HIV and you're not virally suppressed, you could get exceedingly ill, and we would want to watch you very, very carefully and perhaps get you started on some antivirals, which we do have access to. Next slide, please. So let's talk about Jynneos vaccine. who should get Mpox vaccine? Well, I mentioned already, people who have an exposure who aren't vaccinated really should get Mpox vaccine to prevent getting the disease. But as prevention, we would like really people who have been or may have been exposed to Mpox to get the vaccine. That's what we just said. Anybody who's gay, bisexual, or other men who have sex with men, or who are transgender, non-binary, or gender diverse persons with multiple recent sexual partners. Again, this is a disease that's transmitted through close contact. So just being gay, bisexual, or any of these other things that are mentioned here does not mean that you are going to get Mpox. It is the close contact with someone else who has Mpox infection that really puts you at risk. So these individuals are likely during events like Pride, and we know Pride Month is coming up, or other large parties, to be in close contact with someone who may have Mpox, which is why they're called out here. And we have seen, the data have shown that they're disproportionately impacted by Mpox. Also, MSM and transgender, non-binary, or gender diverse people who have recently been diagnosed with an STI. By virtue of the fact that they've been diagnosed with an STI, we know that they have been in contact, close contact with someone else who may have been in close contact with somebody else in the near future, and so that puts them at increased risk. People who have sex at a commercial sex venue, at Pride events, or any large social cultural gathering during the previous 6 months. So anyone who has attended an event like this and their sex partners are at risk, and they should get vaccinated because they're likely to attend another event like this. And so we want to make sure that they're protected. And people with HIV or other causes of immune suppression who have had recent or anticipate future Mpox virus exposures through any of these scenarios should absolutely get the vaccine because of the risk of severe complications. Also, anyone who engages in any kind of transactional sex, regardless of gender or sexual preference at all. So next slide, please. And we know that for every one illness among people who were fully vaccinated, there were 10 illnesses among people who were unvaccinated. So vaccination, complete vaccination, which is 2 doses, 1 month apart, is very protective against Mpox disease. And that we want to make sure that people get those 2 doses, and people who had received Jynneos vaccine and did get Mpox, that one person who did get it out of 10, were at much lower risk of hospitalization and severe complications. Next slide, please. And so here's the problem. Only 17% of Kansans who are at risk for Mpox have received even 1 dose of Jynneos vaccine. And only 11% have received both doses. And we know we have Pride events coming up, and we know that that these individuals who are remain unvaccinated continue to be at risk for Mpox. Next slide, please. And this is a little bit a busy slide. It's got some good information, but what I really want to draw your attention to is the proportion of those vaccinated who are Black, again, a bit underrepresented amongst the total number of people vaccinated. And then also the Hispanic Latino ethnicity underrepresented amongst those who've been vaccinated. So we want to make sure that we're getting information about Mpox and information about vaccine into communities, all our communities, but communities where those at risk may gather, and in particular amongst our Black and Hispanic Latino communities who are overrepresented in terms of disease and underrepresented in terms of vaccination. So next slide, please. And there was a modeling exercise that was done. And the reason vaccine is really important, not only for the individual, but if Mpox were to be reintroduced today with current vaccination rates and at-risk behaviors, the risk of a resurgent Mpox outbreak would be greater than 35% in most jurisdictions, including Kansas, because our rates are so low. So, and because we haven't had a lot of disease here in the state. So critical if we want to avoid another, summer and fall with ongoing Mpox infection and outbreak, we want to get people vaccinated. Resurgent outbreaks in these communities could be as large or larger than the 2022 outbreak, because we know that immunity is relatively low in populations who are highly affected, including those sexually active men who have sex with men in these jurisdictions. Next slide, please. I think that's all I have.
Thank you. Thank you so much,
You're welcome.
Joan. And I see, Jennifer, you have a question. Do you mind if Joan answers in the chat? And I hope it's going to come up during the panel discussion.
Sure, sounds great.
John, I see your hand. We're a little tight on time, but do you want to go quickly?
There's a question from Matt. I can follow up with him directly.
Okay, appreciate it. Thanks. And if we have time at the end, we will. I'm sorry, we're just like super packed today. Okay, so with that update, I'm now going to pass the floor to Courtney Hayden to introduce our panel, and we can get into the heart of our discussion.
Hi. Okay, so as I make introductions, I will rely on Dr. Vicky to pin the individuals who I'm introing. So first we have Kayla Del Rio. Kayla is a nurse practitioner at the University of Kansas who is an HIV specialist and an LGBTQ+ ally. She provides care to people living with HIV, PEP and PrEP, trans-affirming care, hepatitis, and overall internal medicine. Their practice is of 5,000 internal medicine patients, 1,500 of whom are living with HIV, including rural areas of Kansas, including Pittsburgh, Salina, and Garden City. We also have Mary Gonzalez, who is a board-certified doctorate nurse practitioner and HIV specialist. She specializes in HIV, PrEP, hepatitis, and gender-affirming care as well, and she has over 10 years of clinical experience in LGBTQIA+ healthcare. And last, but surely not least, as she made all these introductions, we have Tori Gleason, who is a clinical analyst at LMH in Lawrence, Kansas, currently involved in research on gender-affirming care, as well as physical activity in transgender and non-binary populations, with a passion for health equity around Kansas. She is currently finishing her MPH with a concentration in epidemiology at the KU School of Medicine in Wichita. Those are our panelists, and I do want to give a shout out to Matthew Newman for queuing up this conversation with a little bit of background on history and culture related to HIV and sort of giving us the bridge into the current conversation. So while we wait, on my side, I'm not seeing the pins, but my technology is sometimes wonky. So I'm just going to keep going for the sake of time. And if you have any trouble with the visuals on it, throw it in the chat and we will take care of it. So first I'll just pause. Anybody that I did your intro, did you want to add anything I left off? Otherwise we will jump into questions.
We don't need to add anything, but Kayla and I are actually on the same screen. We share an office, so we didn't want echoing and sound. So we'll be on my screen.
Perfect. Thank you so much. Okay, here's our first question. And it's a two-part, so I probably should have put it in the chat, but I'll voice over the full. So how did the LGBTQIA+ queer community respond to Mpox? And how did that history of HIV and AIDS and or COVID-19 impact the community's response itself? And I'm just going to leave this open. Feel free to jump in with your thoughts.
I think in our clinic, since we specialize in HIV, we were at an advantage because we see those patients pretty frequently. So, there wasn't a day that went by, during kind of the outbreak time that we didn't get numerous questions. So we were able to screen patients a lot easier and vaccinate a lot easier than, other clinics probably would. We had access to the vaccine on site too, which really helped. So in this case, having HIV patients was actually an advantage for us. So
we also do PrEP, and so we were offering that as well, because that's obviously a community that we want to hit, that as you see in the statistics, that it was targeting. I had a few patients concerned because of stigma and it just targeting the LGBT population, but overall I feel like we had a really good turnout, and we did also include patients, partners and other people that were not patients be able to come in and get vaccinated, and then working with KDHE also getting some vaccinations available out in Garden City as well.
And I think for me and my conversations with my community, our community, is that, it's just this constant dialogue, and it's the text messages, often the infrastructure that lives on TikTok and other platforms of where communication takes place, and this interest of how do we protect ourselves, because we learned this during HIV. And I can't say enough about KU Midtown Clinic and the amazing providers that are there, and I adore both of you and everyone else that's there at that clinic, and blessed to call them friends, and amazing resources. And please continue to reach out to them, because to me they are the experts. This is what they do, and they're phenomenal at it. But like Dr. Carlton happens to be a GI doc that has millions of likes, and again through monkeypox, through other things, was able to educate people through TikTok and other platforms. And that's where a lot of the individuals that I work with and interact with receive their information. It's not through Facebook. It's not through something that CDC or KDH&E puts out, which we appreciate. A lot of that information is sought through other ways. And other ways, that's where your health communications is actually coming from and consumed by the community itself.
Thank you, Tori. This is very interesting, because I just learned about the role of TikTok in this narrative from you, Tori, actually, at a recent conference. So I appreciate the context. We touched on this a little bit in the last answer, but I may try to drill down just a little bit into programs or initiatives that have been particularly helpful or productive. So when we look at, I think the language that was used was, we were in a good position because we were previously engaged with people who had HIV and AIDS. So I'm wondering how the programming that was pre-existing, how were we able to leverage that into the space of responding to MPOX? And here's kind of a curveball, because this isn't on any outline. But in the future, are there any of those programs that you think, if something like this happens again, this is who we should go to immediately, or this is a resource we should use immediately?
I don't know if I can think of any one resource. I mean, like I said, we just see our own patient population that is at, the biggest risk in the community. So we just have such a good relationship with our patients established already. I think they just felt comfortable asking the questions and coming in. But I agree with what Tori said. I think a lot of the information they get is from media, not necessarily from, going to the CDC website or legitimate resources always. So, so I don't know that I have one specific resource, but I do agree that, using other platforms besides, just relying on, people to check the CDC website and things is a good idea.
And I would say also targeting different clinics who deal with a large base of LGBT plus patients, so like us and Hunter Health and MCare, and just the different areas that we know we have a large LGBT population. Also, even I've always thought about PrEP and also monkeypox, or any of these things that are targeting these populations, going to clubs that are LGBT friendly and allowing us to post things or things like that, maybe information or brochures or things like that, just to get the information out.
That's incredibly helpful. Thank you. And then can we dive a little bit maybe into what's being said when we're chatting with people, obviously not individuals, but what we're hearing on TikTok. I almost said Twitter, which shows my age. But what we're hearing, what that conversation is looking like, how is the community engaging with the idea of MPOX? And I want to compare this a little bit, because we see the maps and the numbers. And so I'm hopeful this will give sort of that personal element to complement Dr. Jones' presentation.
I feel like a lot of, oh, sorry,
Go ahead. You're
I was
good.
going to say, I feel like a lot of the patients, the questions they would ask, and they wouldn't necessarily tell me where they got the information, I guess, but they want to know, is this really like a big deal? I guess, should I believe what I'm hearing, or, are you actually seeing cases? I would say those were probably, how important is it that I get this vaccine? Is it really that necessary, or are they just making it a big deal? That type of thing. So I think with COVID being so close, a lot of people are like, okay, is this just like another, COVID vaccine, or, you know what I mean? They kind of associate it with that. So.
One of the things I think is that, like, I'm a storyteller, so I apologize. That comes with me and public health. So from a rural experience, one of my individuals that I've connected with said, like, my provider told me that, really emphasizes the men that have sex with men, the MSM portion, and didn't go beyond and expand. Dr. Duvey did a great job of saying, other things, other gender identities, other individuals. But they stopped at the men that have sex with men are more commonly impacted by that. And they said, well, I'm not a man, so this is something I can't get. And so it's that communication where you see it on a PowerPoint slide, and that's from a health literacy standpoint, that's something that's just not continued to communicate to others, that it's through contact. And so again, from a barrier that we see this in patients in rural, we see it in other areas, and not just rural, we see it in urban areas where I live in Olathe and actually work in Lawrence, is that, individuals that, when we identify it through men that have sex with men, and I know that we're going to have this conversation, but someone that says, well, I don't identify as a man. Well, can we get back to anatomical parts? Can we get back to having that conversation of, it's about contact, not something that you have some social term or how somebody identifies as man, woman, or whatever. That's something I think that's important to have in context with this health literacy, health equity lens, that when we have, how can you get, or who is more susceptible to getting contact? And it's that one PowerPoint, bullet point that people hang up with and say, well, I'm not susceptible. I'm not going to get this. And I think it's an important part of this conversation.
Thank you, Tori. Okay, here's my last question, and I'm going to try to queue it up first. So last year throughout COVID, we spent a lot of time. We took a deep dive on different topics. We broke into small groups. Some of them were specific to different populations. Now we have all of this perspective. We've lived through COVID. We've worked with each other, but there could still be partners on this call, or partners of partners on this call, who really haven't engaged the queer community before, who, if something like an Mpox resurgence happens, or Mpox, the numbers went really high, or there was a similar epidemic or pandemic that started with or was perceived to disproportionately impact the queer community. What advice would you give those partners if they say, hey, I want to help, I want to be an ally, but I don't really know much about this, or I don't know how to engage?
I guess just linking them up with the right resources. Knowing where to send those patients or people for more information, with providers that do have experience in that population, if they're not comfortable. I think that would be the best place to start, at least.
And we're actually co-chairs on the Wichita LGBT Health Coalition. I also work at the Little Clinic, and so I have both of those platforms that I usually feed out information and get on those networks and try to network with other people. Because honestly, even as a provider, if you're not comfortable or you don't know, it was very new when monkeypox came out, and even for our clinic, and everybody's like, well, what do we do? And when we looked at the guidelines, it's pretty much, gown head to toe, like you had to be covered head to toe, and it was like HIV all over again, and it brought another stigma, and it was very uncomfortable for patients. I mean, I just went in, I looked at the strains, they weren't as airborne as other strains, and so I would gown up if I was going to take a sample, but I also wanted to make sure that the patient knew that I wasn't just worried about that, I wanted to worry about the person. So I think there's also that stigma around providers and providers being educated, especially when something brand new is coming about. And if there is a resurgence, Like if there's a provider that's not comfortable with it, they're probably not going to have that discussion or even take a sample to send it in, because the sampling process and getting that to the health department was very hard. And it was very hard to understand or fast track that. And I think there were a lot of barriers put in place because of that. So, I mean, if we want to combat something in the future, as also getting providers, like maybe several, get them trained very well so they understand and that they're willing and wanting to teach and wanting to treat and take care of patients with that disease process.
You know, I want to highlight the work that they're doing with the Wichita LGBT Health Coalition. And again, yes, it has Wichita in it, but it's statewide. And that's just something that we're involved in, that we, want to make sure that people know and get providers on there, get your stakeholders in your network built out on there. Also, full disclosure, Dr. Duvey is one of her students, started Outcare Health. Disclosure on that, I happen to be a board member, but I'm not compensated. But we have 50,000 unique visits a month. And that's where people are seeking out information and providers and who they can go to and send their patients to for referrals and get people that are safe from an inclusion standpoint and from a cultural humility standpoint. That's where people go. And so continuing to know where are your people that you can go to that are informed, that are educated, that are, and they mentioned MCare Health, and they mentioned other places now, Hunter Health and Health Corps and some of those other great sites that are across the state. And of course, those are all Wichita that I cited there, but we have great places that are around, and going and figuring out where your networks and where your providers are, regardless of letters behind their name. Who can you go to? Who can you trust? And who's the one that's going to treat your patients? Because that's the thing. Like, I'm afraid to admit some of, like, this is who I am. For instance, I'm terrified of getting a mammogram in Lawrence. This is a large community, right? Those barriers that already exist because of historical harm. I'm going to cite Christina, and I always do, historically resilient communities. We're nervous about those things. And so how do we have places where we know that we can go to, that not only can I get a mammogram, but where can I go talk to somebody about an mpox vaccination? Where do I know I can go somewhere where I'm going to have harm reduction and trauma-informed care be part of that care delivery? Those are important things. And if you don't know what those things are, ask and bring an expert in. There are plenty of them around the state. Wichita State does an amazing job. KU Med does an amazing job. K-Staters, there's some great people all over the place. And I'm a K-State undergrad, so I bleed purple, even though I'm red and blue now. And so bringing those experts in that can make sure that they can educate you to where you need to be and to have in there. But I think those are the things, is building out that network. I mean, we have 92,000 LGBTQ people in the state of Kansas. We have 14,500 trans people in Kansas alone, of 1.6 million people in the United States. That's 2,100 estimated kids aged 13 to 17 in Kansas. So, I mean, start doing the math that we have people that we need to take care of. 56,000 employees in the state of Kansas that are LGBTQ, right? So understanding that this is a part of our population. And from a health equity standpoint, what are we doing to remove barriers and increase access to care? What are we doing from a health communications? What are we doing from a health equity lens to make sure that everyone feels like, I can get taken care of, and I can be seen here, and I can stay in Kansas?
Tori, there's nothing I can say. That was perfect. That was incredible. Thank you so much. Thank you to all of the panelists, both for your input and for your candor. I think it's really important that we all talk about it. I have 2 minutes until I have to hand it to Dr. Jimena, because she has one last important announcement, but we could take one question. Or we'll all just take that 30 seconds and soak up Tori's wisdom, which I think is also very okay. So while we wait, if you have a question, throw it in the chat maybe, and I'll see what I can do to follow up with you. Otherwise, I will hand it over to Dr. Jimena and Dr. Vicky for the last slide.
I'm here. I thought I was being fancy and I was trying to pin you two, and now I can't get out of it. So thank you so much for that. That was amazing to have the three of you. So thank you for being on and sharing. I wanted to, before I open the floor for announcements, I have two things I want to do. Vicky, could you put that last slide up? I want to make sure everybody on this call knows that we're in the midst of annual Black Maternal Health Week. And I just wanted to share this event that's local. It's going to be in Kansas City, Kansas. It's a conversation about healthy, thriving Black families, featuring keynote speaker Stacy Scott. It looks amazing. So please spread the word and attend if you can. Just also wanted to say that the theme this year for annual Black Maternal Health Week, which is April 11th to the 17th, is Our Bodies Belong to Us, Restoring Black Autonomy and Joy. And so I just wanted to share that. I want to take 2 minutes to pass the floor to Carla Rivas D'Amico, who's the new Executive Director of the Kansas Hispanic and Latino American Commission, or KLAC. Just to introduce herself. Welcome, Carla, and thanks for being here. I know she was on. I wonder if she's
Sorry,
oh, there you are.
Hi, everyone.
Yay.
Sorry about that. I'm new to the two monitor life, and I could not get my little mouse on the button to unmute myself. Thank you so much for introducing me. I just came into this role a few weeks ago, and thank you for including me in this conversation. I know that my predecessor did a lot of work around COVID and testing and treatment. So really excited to continue that mantle. You know, as KLAC, I really see our role in this issue as kind of an ambassador to the community from, you know, state agencies and other organizations to provide this information. You know, our communities are in many different places, but when it comes to where we are online, Facebook groups, community Facebook groups that are Hispanic centered are a really huge way that the community accesses information. So I will definitely be putting out as much of this as I can on our social media and in these groups. Please don't hesitate to contact me. I would really love to do a social media like Facebook Live sort of series and interviews with different folks about these issues. And yeah, thank you so much for the opportunity and for including me.
Thank you, Carla. Thank you, Carla. I just wanted to open the floor now to any announcements. If anybody wants to share upcoming events.
I do. Good afternoon.
Hi, Dr. Counts.
With a couple of groups. Kansas Black Farmers Association out of historic Nicodemus, Kansas. Family Counseling Consulting here in Kansas City, Kansas. Two quick announcements. Kansas Black Farmers Association has been able to partner with Rural Coalition, and the USDA is providing a $600 single payment relief payment to all of our farmers and our people who worked in the meat packing, meat processing community who fed us throughout this worldwide pandemic. So we are seeking out qualified applicants so that we can fill out this application, submit it to the USDA so that they can receive this, I'm going to call it a thank you gift for continuing to feed us during this pandemic. So Kansas Black Farmers is covering the state of Kansas. So if you know anyone, rural, urban farmers who worked through this period, January the 27th up until May the 11th, who qualify for that, all they need is an ID and a proof of work. We'll fill out the application for them and we'll get these justly deserved dollars back into their hands. So if you could spread that, and I also put the flyer in the chat for us. The second thing I want to mention is that Family Counseling Association, in partnership with Feed My People, Abby Rice out of Norton, Kansas, we received an Increase the Reach grant. We are going to be working with our teen population, focusing on how to message them. I heard some disappointing news that it's not going to be included as one of the immunization requirements for students. And I am officially a retired teacher, but I still love my kids. We are still going to be out there with these great dollars over the summer, trying to reach as many teens as possible and youth, anyone that is younger than me, and that's everybody, to get vaccinated and to try to reduce hesitancy. So you'll hear from me again and again. I just want to protect our babies as much as I possibly can. So if I can get them to change their mind about getting that shot or continuing to test, that's what our goal and our mission is. So thank you for the opportunity to spread an announcement. This is Tammy.
Thank you, Dr. Counts. Thank you to you and Dr. Holmes for all the work you've done. We're at time. I'm sorry, we don't have more time for announcements. Thank you all, and we'll see you in May.